Good morning, everybody, and welcome to the Health Services Research Association of Australia and New Zealand's monthly webinar series. This is one of the association's key learning activities, and certainly we're honoured with our special presenter today. My name's Rachel Morton. I'm a health economist at the University of Sydney, and I'm the president of the Health Services Research Association. Two things about the association, just quickly. One is our mission, and that is to improve and promote health services research in both countries. And we do this through collaboration with researchers, clinicians, health services, sponsors and industry. And the second important thing to know is that we will be having our biennial conference, which will be in Sydney in December 2021. So looking forward to that. All right, turning to today's webinar, we're very privileged to have Professor Len Gray with us. Len is the Director of the Centre for Health Services Research in the Faculty of Medicine, University of Queensland. Prior to being in this role, he directed both the Centre for Online Health and the Centre for Research in Geriatric Medicine, both of which have been now incorporated into the new Centre for Health Services Research. The centre is physically located in the Princess Alexandra Hospital in Brisbane, and Professor Gray occupies the Masonic Chair in Geriatric Medicine, which is a position that he's had since 2002. He has formal training in medicine as a specialist geriatrician and also in health administration, and has previously held senior management positions in public health systems in Victoria, in general management and in aged care services. Professor Gray's research interests focus on aged care policy, models of aged care service delivery, assessment and care planning systems, and in more recent years, e-health and telemedicine strategies. We're very pleased that Professor Gray is going to lead a webinar on an extremely relevant and important topic, and that is telehealth in the post-COVID era. Professor Gray will speak for about 40 minutes, and then you'll have the opportunity to type in your questions in the Q&A bubble that's at the bottom of your Zoom screen next to the chat feature, and then I will moderate a discussion or question and answer session with our speaker for the remaining 15 to 20 minutes. Over to you. Thanks very much, Len.
Thank you very much. Now, I assume, Rachel, I'm just checking everyone can hear me. Yes, good.
Yes, all good.
Okay, well, thank you so much, Rachel and Sarah, for inviting me and organising this opportunity to talk. Probably never been a more interesting time in telehealth in Australia at the moment because of the changes that have been rapidly introduced in the context of the COVID pandemic. And this talk is really designed to reflect on what the context of those changes are, and just to continue and ask you to reflect on what might be the legacy arrangements beyond September, when the current national funding arrangements for telehealth are scheduled to return to normal, whatever that might be. So, as Rachel said, I work at the Centre for Online Health, amongst other things, at the Centre for Health Services Research at the University of Queensland. And a lot of the work that's and the wisdom that is embodied in these next few slides and in my talk is derived from the work of the Centre for Online Health, which has been at the University of Queensland for over 20 years. And recently we concluded the NHMRC Centre for Research Excellence in Telehealth, which explored issues around barriers and uptake for telehealth, and some of the work that I'm presenting today is a reflection of that effort. So, COVID-19 is, as you all know, created many changes in our society, not just in healthcare, but in terms of the whole operation of society. But regard to healthcare, the kind of moment that we've arrived at is really based around the risk of community spread of the virus and the need for social distancing, which in turn has created a need to deliver healthcare at a distance. And that then meant government felt obliged to provide financial support for telehealth interactions that were previously really outside of the government's funding portfolio. But of course, the question we're asking ourselves today, what's going to happen at the end of all of this? So my talk is really designed to give us here some material to think about in terms of what we will do beyond COVID after September. So the talk will reflect on, just to get the territory defined, we'll talk about what telehealth actually is. I'll reflect a little on the way telehealth has evolved in Australia up till the beginning of COVID, and particularly talk about some unexploited opportunities that telehealth offers us here in Australia. And then towards the conclusion, we'll think about what the impact of COVID-19 has been and what the legacy might be, and in the face of that, what could be done and what we need to do as all of us being influential people in this world, try to set things up to get the best out of what we've learned from this COVID experience. So telehealth, we think of telehealth as delivering healthcare at a distance, and this can be done through a whole variety of modalities, not just video conferencing, which is what most people think about in Australia when one thinks about telehealth. But if you were in North America and you mentioned the word telehealth, people would think about remote monitoring or other forms of telehealth. So it really is, determined by the local culture what people perceive to be delivering healthcare at a distance. So phenomena or activities such as mobile dermoscopy or monitoring diabetes remotely, and a whole raft of other methods of interacting with patients really fall within the ambit of what we describe as telehealth. So that it does include text messaging with patients, for example, sharing of data images, for example, radiologists viewing radiological images are all versions or formats of telehealth. And most of these formats that you can see in that blue box are relatively unexploited in Australia, and I'll talk more about that shortly. So I guess the sort of history of telehealth in Australia really started with state governments providing some support, particularly in Queensland. There's been a long history of attempting to make telehealth a kind of an activity of importance. And then, of course, the Medicare weighed in back in the 2000s and again in 2011. I'll talk about that in a moment. And in parallel, there's been an emergence of private user pay services, which I'll reflect on briefly as well. So Medicare supported telehealth really came into existence back in the early 2000s. Again, I think inspired by the then director of the Centre for Online Health, who was a psychiatrist, Peter Yellow-Lees, created an opportunity for Medicare to support psychiatric consults in the rural communities. But the really big shift happened in 2011, where again, a Centre for Online Health was pretty heavily engaged in designing how specialist access could be secured for folks living in rural communities. And there was a raft of MBS items made available at that time with some fairly generous incentive payments back in 2011. And then in 2018-19, there's just been a slight kind of dip of the toe in the water for GPs to use Medicare funding to support individuals in rural and remote communities. And here we're talking very rural and remote, much more restricted than for the specialist footprint. And then, of course, in March 2020, a set of temporary item numbers were introduced into Medicare to support ubiquitous telehealth. And so this now becomes a universal availability. It can be mediated through video conferencing or telephone. interestingly, there's been quite a lot of discussion back in 2011 about why telephone consults couldn't be supported by Medicare. Many practitioners think that's an important form of interaction that's underfunded. But in the current period, it is a legitimate means of consulting according to the schedule. And again, there's been some adaptations in the face of pressure from patients in the industry. Initially, it was for only permitting bulk billing, and then the uptake was poor and lots of complaints from specialists who often charge considerably more than the schedule fee. And so there were exemptions introduced for specialists in allied health consultations. And then there were some additional incentives provided to GPs and others for so-called COVID-19 vulnerable patients. I guess we're talking about mainly frail older people and very disabled people with particular risks of exposure with COVID-19. So quite a slow kind of evolution up till this year, when there's been dramatic changes because of COVID. So here's the, I guess the line to look at here is the orange line, which is the consultant specialist uptake since 2011, when the item numbers were introduced. That's the number of consultations. At 2011, there was a kind of a view that there would be a pretty big explosion of use, but in fact it didn't come to pass. But as you can see, there's been a very steady and consistent increase in uptake of these item numbers by specialists servicing rural communities. And the level of uptake varies by state. The biggest volumes in Queensland. Queensland has the most distributed population of all the states in terms of regional and remote centres, and it had built some of this telehealth capability. Quite a big infrastructure investment happened in Queensland before other states, but that you can see that across the board there's been pretty substantial growth in Medicare funded specialist consultations over that 7-year period. In Queensland, there was about 2012-13 a concerted attempt by the state government to incentivise telehealth and indeed public sector item numbers or activity-based funding, if you like, was introduced back in about 2013. And that's seen a really dramatic increase in the use of telehealth in the public hospital sector in Queensland. Indeed, that's the data from 2018 just keeps on going up. In our own hospital at Princess Alexandra Hospital, we went in 2012, we had 4 disciplines operating telehealth services, and now it's up to around about 60 services using telehealth. So really dramatic changes in advance of the COVID era. And if you get on the web and look for a doctor, you'll find these kind of sites where various types of commercial telehealth services are offering a range of services. These are all user pays, and we don't know what the level of uptake is. What we do know is that there are around about 17 or 18 of such services operating in Australia. Presumably, many are continuing, so they're viable, but we don't know what the volume is. And they've often found sort of niche activities that don't get well served by Medicare or traditional general practice or traditional specialist practice, and have been trying to develop services outside of the government-funded sector. So we in the telehealth academic world think about telehealth as having a range of benefits, and the primary benefit that everyone perceives in Australia is, well, folks live in rural communities, travel's an issue, access becomes a problem, some kind of alternative communication or consultation strategies required. So that's been the kind of primary driver of telehealth uptake and investment in Australia. However, there's fairly strong, if not obvious, evidence about the ability of telehealth to offer an efficiency gain in the way in which health services are delivered. If one just thought about it from the patient perspective, there's a massive efficiency gain because patients are required to go and visit doctors and consume time. We'll talk about that again in a minute. But even when they've got fly-in, fly-out, or doctors, health professionals traveling, there's an efficiency opportunity. But many other processes that can be delivered through telehealth are made more efficient because of the way it's configured. And the other dimension to all of this is that through a combination of access, efficiency, and other attributes that are associated with telehealth, in some circumstances, health outcomes could be improved and you get better results in managing certain conditions than you would with conventional approaches to healthcare delivery. And I'll talk about that a little in a moment as well. So this is a study that was published in 2015 in the United States, which examined the costs of ambulatory medical care in the United States. And in a nutshell, for a visit to a physician, they calculated that a person consumes about 121 minutes of their time, of which 37 minutes is travel, an hour or more in the clinic, 20 minutes with a physician, and about 20% of people are accompanied by another person. And they calculated in 2015 dollars an opportunity cost to the economy of about $43 a visit. But if you think about it from the alternative telehealth solution would eliminate all but 20 minutes of that time and would also eliminate the need for an accompanying person to travel with the person, even if they were with the person in their home or elsewhere. So there's a big dividend for patients. Now, of course, the health system doesn't pay for patient travel in most instances, so it's kind of blind to this social inefficiency. Kaiser Permanente, you will be aware, a large provider of healthcare in the States, basically is re-engineering the way it delivers healthcare using telehealth. And back, I think in about 2017, it had announced that more of its visits were through virtual means than conventional encounters. So this is a very dramatic development of telehealth activity. About less than 1% of interactions in Australia are telehealth at the moment. So this is a very different model of healthcare delivery. So Kaiser offers a range of opportunities to use telehealth. For example, for simple conditions you can see listed on this slide, constipation, for example, they'll provide an online quick consultation for subscribers to their service. And so a very different kind of front end to primary care than you might see in Australia. Babylon Health, a British company that's now reaching out to the rest of the world, has developed a model that involves first interaction with a robot, simple kind of interrogation of the problem, and behind the robot there is an opportunity to talk with a doctor through a video or telephone consultation, and then that might be advanced to an in-person consultation. So they've kind of designed a system that really is called, we would call telehealth first. The first way you interact when you have a problem is through a telehealth modality from the convenience of your home. And depending on the outcome of that first step, it may advance to a more conventional approach to interacting with a health practitioner. So this has potentially some advantages in terms of efficiency of how the health service is used. It also has massive convenience for users. So this model began as a private enterprise, but the NHS has found this, sorry, I'm just missed this point. So this is Babylon's mission. They're trying to find a place in the world, along with quite a number of other large companies like Amazon and others are trying to build a capability in healthcare that one day, potentially very soon, will arrive at our doorsteps in Australia. And I'll reflect on that a little bit more. We were certainly talking about this a lot last year before COVID came along. So the NHS has found this approach appealing, has invested in a few pilot sites, including in London and Birmingham, I think. Individuals can subscribe, pay about £90 a year, and they get a whole range of benefits that you wouldn't get through the traditional NHS, including such things as requesting a recording of the consultation after the fact. So you can play back the consultation, and we know that would be an advantage. Patients don't digest everything that's discussed. So these are very different kinds of attributes than we would see in a conventional consultation. I'm hoping you can see as I talk about these things that that telehealth potentially can be better in some circumstances than conventional healthcare practice. We're captured in Australia by the idea that the visit to the doctor face-to-face is somehow the gold standard of how one would interact with a healthcare professional, and everything else is a compromise. We would take the view that it depends what the problem and the circumstance is. There are a variety of ways one can interact with health professionals, and really one should not use the conventional interaction as the sort of gold standard against which you judge other things. There is a better way for many problems. So Babylon has a very substantial presence now. I think about 40 or 50 kind of services with this front end in Rwanda, for example. So they're looking for opportunities to extend internationally, along with some of those other companies I referred to. Our university, look, the garbage is being collected at home here. Forgive me if you can hear it. We teach medical students from Oxno in Brisbane, but we're very aware of some of the innovations that occur there. So if you have hypertension, diabetes, or other chronic diseases that would lend themselves to remote monitoring, and you're a patient of the Oshna health system, you're offered an opportunity for management of your condition remotely through their telehealth, effectively, or their digital health service. And on referral from your primary care doc, say for hypertension, you'll make one visit to the OBAR at Oshna, where you'll be trained how to use an app and how to take your blood pressure or manage your blood glucose readings or whatever. That's one interaction in person, and subsequently the service never sees you again. And the whole service is, in this case, for example, hypertension is managed by a pharmacist and a clinical coach remotely, who are very aware of your blood pressure recordings and will adjust your medication accordingly and provide quite a range of advice, mainly by messaging, but maybe pick up the telephone or video conferencing, but predominantly through messaging and monitoring. So they get device training at the OBAR. They're provided with a link to a coaching service. They never meet the people in person that are providing the coaching. They continue to be, but the coaching service provides monthly reports to their regular doctor, whom they may or may not need to see through this process. And but they have a very sophisticated system that keeps track of their, in this case, blood pressure, and that not only, you know, with lots of kind of intelligent analytics kind of driving it. So when people stop taking their blood pressure or they go off track, then they reactivate the case, they make contact with people, and it's a very different kind of way of the traditional approach that we have of people visiting their doctor, having one blood pressure recorded and an adjustment of medication. That strategy, the traditional strategy, has about a 50% failure rate for controlling hypertension. And my colleagues at Oshna has described the traditional approach to managing hypertension as a failed system. It doesn't work for half of people. So here's a chart from a research piece that they conducted. They ran a matched controlled study, in this case, of persons with hypertension who were shown after 60 days that they had 62% control of blood pressure compared to the control group of 13%, a very dramatic difference in outcomes. So again, I'm pointing out that telehealth can be superior to conventional practice. In this case, conventional practice is regarded as a failed approach to managing hypertension. I'll just reflect on something we're doing at Princess Alexandra Hospital. We've been very interested in, like many big public hospitals, run rather large diabetes clinics for type 1 and type 2 diabetics. And we tend to congregate, gather a large number of poorly controlled diabetics in these clinics who seem to come for the rest of their lives, even though there are aggressive attempts to discharge back to primary care. So we've re-engineered the way the diabetes service is managed in a tertiary centre with the goals of promoting self-management, improving patient convenience. This, we believe, will increase compliance, improve glycemic control, and reduce demand on the clinic. And we ran and so this requires a cloud-based data repository. It requires staff, mainly the diabetes nurse educators and endocrinologists, to have a watching capability over diabetes patients that are in the clinic. And they are able to track glycemic control through RBGs and insulin, watching insulin dose prescription. And most of the work can be done remotely without, usually with messaging or telephone work in some cases. And the opportunity to, so we started this model by saying, well, if everything's fine at the next scheduled appointment, then we'll either defer the appointment to the next, to a later time, discharge the patient, or have a telephone or video consult with some messaging supporting everybody, however. So the app that we use actually messages the patients internally, and so if things are going well, the patient will get a message and a deferral of their appointment. We recently concluded a small RCT of this model, well designed, I think. The patients in the intervention group improved their HbA1c by about 1%. And the control group attending this wonderful tertiary clinic had stable HbA1cs over a 6 to 12 month period following entry into the trial. So they get to a point where they can't improve. So what the service is doing is adding a 1% improvement in control. And more importantly, the nursing time was reduced by over 50%. Patients like this, and 1/3 of the clinics were cancelled. Visits were substituted with a telehealth or were deferred. And that's early days. We think that number will be greater than 50% eventually. And that's been a research-only service until recently. We are now rolling this out to 3 districts in Queensland in the next year. So, I've gone through all of that just to give you a sense of what telehealth might or should look like. So let's think about what we would like to see in the future with that kind of knowledge on board. So first of all, it should be an option for all patients and health professionals. This is an alternate method of interacting or creating relationships between patients and health professionals. We think it should be available for everybody. Now, a major goal will be to improve health outcomes, and this could be mediated by a much more flexible and intimate mechanism of communicating between health professionals and patients. And this means texting, email, telephone, video, customized to the circumstance in which the problem that's being dealt with presents. And so this will result in improved access to information and advice for patients. Greater patient convenience. Well, you think about why do we care about patient convenience? If you've got to go to a diabetes clinic, you have to take half a day off work. You're going to have to pay for parking. It's a really problematic thing. So at the margins, a lot of patients simply won't go. But if they're offered a 10-minute or a text-based consultation at their convenience, that may result in enormous improvements in engagement and compliance. So the other dimension to this is to think about system efficiency, say thinking about, for some problems, telehealth first triaging strategies, ensuring that patients are maximally empowered to manage their own conditions, and ultimately less facilities. Look what's happened in the COVID era. You go to a general practice, it's half empty. Would we need so many health facilities? What about all these big outpatient clinics at hospitals? How many of those seats and rooms are really required if you've got an alternative? These are really big opportunities. So, as I said, our work has been given to thinking very carefully about barriers to telehealth uptake, and we've wrestled with these issues for some 20 years. So first of all, there's system and individual inertia. If it's working well for the health professionals, they're making a good income, their waiting rooms are full, why would you change? Secondly, the problem of getting things started. Changing from one system to another inevitably leads to inefficiency for probably several years while you change practice. So there's a big mountain in front of one when one tries to do things differently. Lack of exposure, lack of familiarity, lack of training in doing things differently. Just now we're starting to train medical students how to do telehealth properly. There's an art that one has to learn about how to sit in front of a computer and talk to a person, for example, or how to message people in a proper professional manner, just like bedside manner. Then there's the problems of infrastructure. You know, what's the software look like? How clunky is it to use video conferencing? What sort of equipment does everybody need? What about the patient end? Lots of things to think about there. There are financial disincentives to do telemedicine. Very hard, harder to charge patients. We haven't got the systems in place. Prescribing arrangements need to be adjusted. Up till recently, one had to kind of get hold of a physical script from the doctor in order to get a prescription executed. Concerns around safety and security. You know, is there an issue about doing things a different way that might compromise the clinical outcomes? And what about security issues in regard to using video conferencing and messaging services, email and so forth? All big issues that have to be dealt with. And then, of course, we're particularly, the federal government is particularly apprehensive around cost containment. If you have a massively convenient service at low cost, it could potentially be a runaway train. You know, I have an itchy finger, why don't I get a consult, you know, whilst I'm sitting watching my television at home on Friday night? To what extent should we be trying to subsidise those kind of inquiries? So there are a whole range of challenges. So COVID-19 has provided an interesting opportunity for us. Suddenly, the vast majority of practitioners are becoming familiar with communicating with patients through alternate methods. Most of them would have used the phone at a loss up till now, but now they're being paid to interact with people using telephone or video conferencing. Secondly, the software environments, particularly primary care software, is starting to be constructed to provide critical features like waiting room, virtual waiting rooms for people, and also integrated video conferencing into the desktop so that you don't have to open up another system when you're communicating with patients. There is a large-scale Medicare experiment with telehealth. So Medicare is allowing people to exploit funding arrangements. So what exactly is happening with that is not clear yet, but we really want to look at what the use looks like and to what extent it is effective and to everybody's satisfaction. So now very importantly, patients, not just because of their healthcare needs, but actually because of their personal needs, are becoming extremely familiar with video conferencing. So a large proportion of the population now knows how to use video conferencing, so that the problem, the barrier of interacting with a health practitioner in that environment is sort of evaporated, I would suggest. So what can we do? Let's think about this. So I think it's incumbent upon us to understand the uptake in this period. What's actually happened? What are the benefits and deleterious effects of having this telehealth alternative? Where are the strengths of it and where are the weaknesses? This warrants careful investigation. Secondly, we need to give some thought, based on what we know about other systems, what the research shows, what we believe would be an advantage of telehealth that's already sort of available there to some extent, at least in the communication component of telehealth. What should survive beyond COVID-19? Let's try to get the wish list. Thirdly, what policy initiatives are required to facilitate a new set of arrangements? So what does the funding model look like? How would governments at both state and federal levels adjust the incentives to adopt the best elements of telehealth? And how would we trade off the risk of patient hyper-convenience against the problem of potential exploitation and blowout of Medicare costs? A very, very important issue that has to be wrestled with. And ultimately, and I'm talking months, of course, we haven't got long, we've got till September to consider what would be the legacy arrangements. There needs to be an implementation plan that would think about including monitoring and evaluation, a kind of research dimension, to make sure that this changing activity is carefully watched and adjusted appropriately. Now, COVID hasn't promoted remote monitoring, so there's a whole other world of opportunities in telehealth that should be introduced into standard practice that needs to be run in a parallel agenda. So it's not, COVID hasn't opened the door to everything, and there's still many unsolved problems around this telehealth issue. So I want to refer you to the Centre for Research Excellence telehealth site. There's a couple of things there that you might be interested to look at. One is the final report of the CRE, and perhaps even more interesting, last year, curiously, just in advance of this COVID experiment, we put a lot of work into thinking about a policy strategy for the evolution of telehealth in Australia. There's a document there on the website that you might be interested to have a look at. So this is a time when it's been one of the great things about COVID, if there is to be one, is this big experiment that's running at the moment that will inform all of the relevant stakeholders about some of the additional big opportunities for telehealth. So I think that's what I have to say. There's some websites there where there's some really valuable information if you should be interested. And I think in a moment we're going to take questions, but I do need to remind you on behalf of our group that there is a conference, hopefully. I'm not sure if it's going to be virtual or in person. Let's hope it's in person, but that's in December this year. So thanks, Rachel, and thank you everyone for listening.
Terrific. Thanks very much, Len. That was absolutely fantastic. Where would we be able to get a copy of the final report from the CRE? Was that at the CRE website?
Yep. If you go back to, if you go to any of those websites, but if you go to the CRE, if you just type in CRE Telehealth UQ, you'll find the reports there on the website.
Okay. All right, terrific. Yes, we do have a number of questions, and I've just sort of grouped them into general themes. If anyone now would like to write in their question, please add it into the Q&A section at the bottom of your Zoom screen. All right, so Len, a couple of people have commented on some of the advantages they've seen through telehealth. And one of those is the reduced number of people presenting at emergency departments. And I think one of your apps or programs looked specifically at sort of triaging the community with their questions. Could you comment on what you've seen either at the PA in Brisbane or other hospitals in terms of the reduced number of presentations at EDs?
I'm well aware, like many in the audience are, that there's been across the board reductions in demand, in healthcare demand. This is a very interesting element of this whole experiment. Is this a result of fear of attendance, deferral of problems that will later emerge as needing or some sort of real phenomenon about the incidence of problems that require attendance? Some things like where individuals are, for example, accidents may be a phenomenon that's kind of reduced because people aren't traveling as much. But so I don't know the answer to that. But of course, there's lots of people looking at this forensically at the moment to try and dissect out the what is going on. But obviously, there's going to be some real significant learnings. In terms of how we configure our health system, though, in terms of the front end and the ability to respond to people who in a moment of health uncertainty will look for a place or an advice that reassures them that they don't have a huge problem that could be attended to otherwise. That seems to be the scenario that then leads people to escalate to an emergency department. The other piece of it is, what's the charge going to be? Because the out-of-pocket expenses of venues other than emergency departments are maybe prohibitive to a lot of people. So I think in designing the front end of our health system with a telehealth paradigm in mind, we need to think about those cost factors and convenience factors and the competence of the advice you get, because you do want to be reassured through these media that you are getting the best possible advice. So they're the design challenges.
Yeah, well, that leads into actually another topic or question here, and I'm just going to find it. It was in relation to the Oshna health system you demonstrated on your slides. And the question from Lena Sanchi is, are patients in the Oshna health system followed up for any adverse consequences of not checking in during the care of a chronic issue with a GP? So are there any complications or comorbidities that are missed?
I don't know that for certain, but they do have quite a, excuse me, I'm not sure what you're seeing on the screen. I can stop sharing, maybe people can talk to me. So the coaching service obviously keeps track of folks and how they're going, and one of their functions is to kind of make sure people attend their doctor if there are other problems. But I don't have any. I'm not aware, and I don't know that they've talked about this in their publications about inadvertent poor outcomes. I guess that's what people are worried about. As we are at the moment, people not going to their doctor. What happens around monitoring of particular risks, cardiovascular, cancer risks, all those kind of things. I don't know the answer to that. It's obviously a question that needs to be thought about very carefully.
Sure. Okay, thank you. And there's quite a few questions and comments around GPs. GPs utilising the current MBS item numbers for telehealth, also around integration of care between GPs and specialists using a telehealth model. So specifically, there was one question around, can specialist GPs claim the specialist reimbursement for telehealth was one question. But then more sort of integral, I guess, was, for example, how does the PA communicate with the patient's GPs? So if you could comment on integration between specialists and GPs using telehealth or current systems that are in place, that would be really good.
What a great question, because, you know, all of us probably think what a weird system we run here with without the, you know, we have this arrangement where GPs refer to specialists and they go and they make a booking and then they send a letter back about 3 weeks later, and you kind of think how analog is that? So we've got a project at our vision for our diabetes service, for example, goes very much to this point. So, of course, the big tertiary hospitals are trying to discharge people all the time. It's a kind of a, you know, why do so many people come to the clinic? They should be seeing their GP. There's a whole bunch of reasons why that happens. One is financial, out-of-pocket expenses. Another one is they believe the hospital knows what it's doing. They want to be handled by a specialist rather than a generalist, you know, all that kind of stuff. So the way we've been imagining this, and we're actively working to build such a system, is that the monitoring facility should be primarily available to primary care docs, to GPs, so that they should be able to see the same data that the patient is sending to the hospital. And indeed, the primary focus of where that data should go is to the primary care practice.
And does that happen at the PA at the moment? Does the patient's GP via HealthLink or any other system?
No, but that's the plan. You know, the technical work that has to be done and the compatibility issues, interoperability, these are massive challenges, but the vision is to do that. And the next thing we'd like to see is the ability of primary care docs to consult with the endocrinologists and the diabetes nurse educators virtually. Like, this doesn't look like it's going well. Here's the insulin regime, here's the RBG profile, here's the HbA1c, here's the renal function, already available to the specialist. Our specialists are getting pretty good at doing online consults, looking at these data systems without seeing the patient, and probably could, in many instances, give advice in a virtual environment, so that the GP then is empowered, confident to provide advice to the patient without the need for the trip to the hospital. So that's the model that we are trying to build. And, you know, obviously, there's all sorts of issues around this. Some endocrinologists are very traditional. They think the patient needs to be in front of them in the room. They have to examine their feet, etc., etc. We're not convinced that needs to happen all the time. The number of people that need to kind of appear at the clinic at the tertiary level probably could be substantially reduced. And with better control, there would be fewer people coming. So that's the vision. And this would apply to many, many other health disciplines, really. You know, these chronic disease management type scenarios lend themselves very well to that kind of approach, but I can see opportunities to do this with many of the specialties that involve chronic problems in particular.
Okay. So another question, a little bit more on the practicalities. Again, focusing on GPs, it's been reported in the Pulse IT publication that most Australian GPs have adopted the telephone telehealth, and that once COVID-19 restrictions ease and possibly that item number disappears, that GP consultations will go back to face-to-face. Do you have any thoughts or tips on how to encourage or continue and extend the role of telehealth, whatever format that be, for primary care?
Yeah, what we don't know is what the kind of ideal mix would be if everything was equally enabled and there was a neutralization of the financial incentivization. I do know that lots of people, so you've got very, very, very different scenarios. There's folks with a bit of hypertension and hypercholesterolemia who need repeat scripts, who would be more than happy to take their blood pressures and have their cholesterol checked periodically and never show up.
Mm-hmm.
You know, very, very occasionally.
Yes.
On the other hand, you've got frail people who can't, you know, who really, it's a chore to go to the clinic. You know, it's a major undertaking, and particularly in the COVID era, they're frightened to go to the practice. So those kind of range of scenarios demand different solutions. And what we're advocating is, you know, a blended approach to how you interact with your patients that is not driven by financial incentives, but by what best suits the circumstance or the problem that you are trying to address. And so just a shift in balance away. Now, telephone's not bad, but of course, the more data you have, the better the judgments you can make. So, I mean, managing type 2 diabetes with a telephone, providing you've got an app so you can see what's going on, is probably perfectly fine. I know endocrinologists in Europe who basically manage all their type 1 diabetics on their phone. They don't actually see them at all, hardly ever. And so there is a better way. Now what we've got to do is design a framework that encourages best practice, which is a blend. So this is the work we have to do, and it won't be easy to sort it out, but that's really the challenge that we have, is to get the right mix. Yeah, I think what you're saying, well, they use the phone because it's simple, it's on their desk. Yep. They don't have to kind of log into anything. And then the patient end may not be set up correctly, but I think some of that's getting fixed at the moment, and I think inevitably this sort of approach will be ubiquitous, as long as it's not disincentivized.
Yes, yeah. And I think there's lots of people on the webinar who are also very hopeful that this is not disincentivized, you know, at the end of September. Just on the comment about access and people, the community having access to the technology that's required, other than a telephone. What have you seen, or what do you know in terms of access to healthcare for people who don't have an internet connection, don't have a computer, don't have the funds to purchase a webcam, etc.? What is your sense of what's going on for those people?
It's an increasingly small minority, of course, and that's not meant, I'm not meaning to be glib about that, but that's been the kind of catch cry of, you know, older people who are not well off, of course. Well, I think that's where we've got to think about what sort of demand profile would those people have. Is it worth the public health system trying to invest in giving them the wherewithal? That certainly was the way we used to think about this. I just don't know how many people would be in that circumstance now. I think it's more a matter of simplicity of the interfaces and making it easier for frail people to use devices. Certainly, lots of people have done work on that.
Yep.
It's certainly an issue, but no matter, you know, if you think about it this way, so if you live in an RACF, aged care facility,
yes,
right, and you have a chronic disease that might lend itself to treatment by a rheumatologist or a neurologist, what are your chances of getting that service? Basically zero. Basically zero. So we already have, with the conventional approach, you know, really serious problems of access, equity of access. So, you know, there's work to be done here. And I think that's where telehealth can partially or largely fill a big hole in the system.
Yes.
That's certainly the way we've been advocating.
So, Len, I think there's certainly the viewers today, there's a lot of support for telehealth, and there are a few questions around what can the community do? You know, not only the health professionals like this, and there's certainly some gains and wins. There's a lot of things that need to be evaluated from a health system perspective, but a lot of you know, people who are receiving care really like it as well.
Mm.
What sort of, you know, politically or as a, you know, a group community action or force do you think could be done to provide the message to the Department of Health, to the Australian government, that these services and the reimbursement of them need to stay beyond COVID-19?
My own view is that the government is increasingly aware of the value of this. I think the big fear is abuse. You know, the fear is that it will be exploited and turned into a runaway train. So one of the, and I'm sure many folks on the webinar are aware of this anxiety. So I think we've collectively got to think about how that could be managed, because, you know, it's often the tail wagging the dog problem. That is, you know, the abuse and exploitation ruins it for everybody. So we have to deal with that issue. Otherwise, I mean, amazing development in the ubiquitous use of these technologies to enable people to communicate we've seen in the last 10, 15 years. So we really will find over the next 5 years that this will be, you know, using remote technologies to communicate amongst each other will be the standard. In a way, medicine is behind the community standard in terms of communication. We don't want to not exploit that opportunity to provide better healthcare, I feel.
Yes, yeah, for sure. Okay, well, Len, thank you very much. We're almost out of time. I think it's been a terrific presentation. I really thank you for your expertise and insight and covering a range of issues and considerations. We've had a lot of comments on the chat, and we've covered most of the questions that were asked by participants. People have contact details for your centre, and also a number of resources that have been put up in the chat as well about supporting telehealth service provision. So I would just like to say, on behalf of HSRAANZ, the Health Services Research Association of Australia and New Zealand, this has been an excellent webinar. Thank you very much for your time. And also to Sarah Green, who set up the logistics for this, and to the participants and your engagement and questions. So thank you very much, Len, and wish everybody a good day, and we've finished on time.
Very good. Thank you.
Thank you.